Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
And welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky. Co-host Dr. Karl is in the same square with me again. We brought back one of our favorite special guests, Dr. Rachel Pessah-Pollack. She is an endocrinologist and also I would consider more of a bone expert than my brother, who's also an endocrinologist. But today we're going to be talking about vitamin D. There's some new vitamin D guidelines that kind of threw everybody for a little bit of a tizzy. I don't know. Not everybody.
Not
some
everyone.
people.
So depending on how they understand the methodology and what they were trying to answer, I think.
But just some background. I remember when I was in residency, just starting out in 2011 in family medicine, and it was kind of a joke. They do what's called like a case report, and you'd have to guess what the issue was. And it was always something with fatigue and whatever else. And part of the differential, someone would always be like, vitamin D deficiency, something like that. Everything was always blamed on vitamin D deficiency. My brother and I went to an obesity conference in 2008 or 9
or 10.
10, whatever.
Yeah,
10.
ten.
And one of the guys who is basically attributed to making sure everybody's taking tons of vitamin D is this Dr. Pollack.
Who, by the way, was the lead author of the old Endocrine Society guidelines, if I'm not mistaken. I have to look back,
But just, before I'll let Dr. Pollack talk, but this guy, he seemed kind of crazy, and he had these slides that basically attributed everything, any imaginable issue related to vitamin D. And I was in med school at the time, and I was like, I don't know, sounds good to me. He seems to know what he's talking about because he showed all sorts of pathways. But we're coming full circle and maybe becoming a little bit more reasonable. And I think that's what these.
Back then, I think, it seemed like everyone thought vitamin D and supplementation, it was like, the new magic answer to everything. But as with everything, there's a lot more nuance and middle ground. And so the Endocrine Society decided to update their guideline, do a whole new systematic review, but of very specific questions and for specific groups. So I want
to ask you, doctor. So, like, just a little bit of vitamin D background. Why do you care as an endocrinologist about vitamin D? Because you guys are the bone experts, and that's from what I understand. That's kind of the big,
the OG topic of vitamin D. I think osteomalacia.
Can you give us a little bit of background of kind of a little bit of physiology? Some doctors listen to this, but a lot of patients listen to this.
Sure. So as you said, I'm an osteoporosis doctor. So I see a lot of people that are at risk for falls, fractures, and quality of life, issues as a result of that mortality. And so vitamin D is one of those vitamins that we check. Now, your body endogenously does make vitamin D, right? If you get sun exposure, you make vitamin D. What we're talking about when we're measuring is something called a 25 hydroxy vitamin D level, and that's what your body is making. That being said, in specific populations, we do know that there is a benefit to it. Now, what's that optimal range? That's certainly a controversial part, and specifically I'm talking about within the osteoporosis field. But that other part of it is that calcium and vitamin D together are really important for bone health. And, we'll discuss a little bit, but some of the limitations to the studies that they highlighted in these new guidelines were on calcium and vitamin D together. And so it's hard to pull things out. And to what you were saying, vitamin D is an easy solution for everything if it worked, right? I mean, when you look at studies of health equity, it's a very inexpensive type of supplement, and the goal would be to provide access to everyone for this. So if it worked, it would be beneficial. What's interesting about these guidelines is these are guidelines for healthy people, and that's what's unique about it. They were specifically looking at pretty much not my patient population, which is osteoporosis patients. They were looking at healthy people and the role of monitoring with a 25 hydroxy vitamin D level and treating. And taking a step back, unfortunately, they didn't find data to support what we're mostly doing, which is checking 25 hydroxy D levels in all different populations. And they really narrowed it down. So I went to the Endocrine Society meeting, and on June 3rd, they unveiled, in front of a very large audience, these guidelines. And they came out with what they called, a few recommendations for populations that really would benefit from vitamin D supplementation. But the bigger part of it is all these populations that they don't recommend doing any screening on. And so the old Endocrine Society guidelines in 2011 said, well, we're going to define vitamin D sufficiency and insufficiency. And we're going to say, you're sufficient if you have a vitamin D level of 30. And if it's between 20 and 30, you're insufficient. And then deficient, even lower than that. And I think a lot of us really grab onto that because we can measure that level, treat it, and follow it up.
Yeah,
That's a
I
lot
know.
of testing.
I certainly do. And I like to use terms that have some definition. So I always am very into saying those things. I use sufficient, insufficient,
Yeah,
deficient
right.
because of that guideline.
Exactly. And this guideline says stop.
Yep.
Don't use those terms anymore. We don't support you using those terms in healthy populations. And so for somebody like me or on a lab, if you look on the Quest lab slip, it gives you those reference ranges. It says 30 to 100 sufficient, 20 to 30 insufficient, and then lower deficient.
And it always references Dr. Hollick. I always see his name on it.
He was the leader
I know.
of the Endocrine Society.
I'm always laughing.
But here's the other background that I don't think lay people definitely won't know this. And even a lot of doctors, unless they really know Endocrine Society guideline development, but also a lot of the newer guideline development protocols are using, these grade methodologies, which are very stringent upon very, very high quality evidence and randomized controlled trial evidence. So is it worth screening? And then is it worth doing anything about a certain level and who's going to benefit? And it's very hard, evidence-based stuff. And so it can come across as lacking some flexible nuance and other data. And that's, that's a whole nother conversation for another day. But I think that's part of what gets people so uptight when they see these recommendations. And then also the words they use matter. They use the term suggest when it's essentially sort of soft evidence, saying, well, the evidence essentially, shows benefit versus the risks. Whereas the word recommendation this is like definitive, absolute. The evidence is very clear. And you'll notice most of the guidances are suggesting things.
That's a great
Can we
point.
back up and
And
talk about
also very low quality evidence. I don't know if you noticed, but almost every recommendation, except for a few, are low quality, very low quality evidence, which leads you to believe that clearly we need more data. And right now we're just in this kind of holding pattern of absence of data forming recommendations.
Could we back up and just talk about the basic physiology? Why do you care about your vitamin D level being above a certain threshold? Because I think this is like some basic medical students type of stuff that I think the lay people are like, I don't know, I need vitamin D, it's good. But as an osteoporosis doctors, you guys care because of bone formation and loss.
Yeah. But then there have been a lot of suggestions over the years of all the other different vitamin D, extraskeletal things. And that's what this was talking about.
The original
the OG
reasons that you don't want your vitamin D levels to be low is just because of bone metabolism.
Yes. And so, when you have a low vitamin D level, then your parathyroid hormone level starts to rise and you start to increase your intestinal secretion of calcium, right? So you're losing calcium. And then as your PTH level goes up, you break down bone. And so there was that assumption and studies that showed this, that, if you have a threshold 25 hydroxy vitamin D level about 20, that's when you start to see a PTH level rise. Some other studies have said, well, no, really it's 28 to 30, but you're trying to prevent that bone loss from secondary hyperparathyroidism. But as you were saying, there's all these different studies out there showing a benefit to your immune system, benefit in the setting of reducing the risk of cancer. I mean, there are all these different, kind of impossible to prove associations. And as a result, it seems like there are confounding factors that allow people to say, well, it looks like there may be an association, so why don't I do this? I mean, we saw that during COVID, right?
Yeah. Well,
you had people taking 10,000 units, vitamin D a day, trying to prevent the development of COVID.
And to that note, I will say that I tell my patients this all the time. The only time I ever was consulted as an inpatient for hypercalcemia that was not parathyroid related, that happened to end up being due to vitamin D toxicity was like kind of during and after COVID. And it was these people who were taking huge doses of vitamin D because the online influencers said it was going to prevent COVID. Now, there may be truth to that, but they end up
Right.
overdoing it and actually ended up hypercalcemic. The second thing I was going to say is I remember the studies, I think I was in fellowship when this was kind of talked a lot about, is that the parathyroid hormone sort of nadir, meaning the most optimal lowering of parathyroid hormone was with that vitamin D of around like 30, 32 or something like that. And that's partly where that came from. But that didn't necessarily pan out to be beneficial for bones, and especially not overall, because then anyways, it got complicated and was very nuanced.
It is complicated, but that is where that threshold came from exactly. And then, just to say that in this guideline, they do specify certain populations that clearly do benefit. And so, I know you all
Yeah, we
have
should
kids. I have
probably
kids. For the
mention
1 to 18-year-old population, they do recommend empiric vitamin D supplementation, and that's to reduce the risk of rickets. So there is that recommendation. And then the greater than 75-year-old population is the recommendation to start vitamin D empirically, as well as during pregnancy. And then I don't know if you saw this one. High risk prediabetes patients should
Yeah.
start on it to lower the risk of progression to diabetes. I mean, how many patients do you have that are prediabetes? I mean, this is
Everybody.
Well,
significant.
yeah, I mean, and that gets into, where they talk about, people at high risk of these problems, and obesity, being one of those somewhat controversial things, and obesity
Yeah.
obviously driving prediabetes. And certainly as someone into the cardiometabolic stuff with endocrinology, I have been paying attention to all that over the years. And it's been somewhat surprising to me when the trials do kind of show like, hey, there is some benefit. And that's what they found in their systematic review.
Is there anything in the review that recommends actually checking your vitamin D levels?
No.
So they
No,
just think,
For
you're
healthy
not
people.
recommending, they're recommending
okay,
empiric treatment based on compiling all different studies, and then they provide a reference range of what the studies did, let's say 400 to 3,000 IUs, and then they provide you the average to recommend a supplement with that. But they're not recommending treatment based on an actual level. And again, with that, they're not defining what a good level is,
Yeah, because the
which is
studies
really
don't
hard to
really
define,
showed it.
honestly. It really is hard.
as an expert, when are the good time? When should we be checking a vitamin D level?
The true indications for checking it. This gets into
Great.
our world a lot.
Yeah,
So
let's
Yeah,
hear
that's
what
a great
Dr.
question. So, certainly anybody that has a bone disorder, I think osteoporosis, when you have malabsorption, celiac disease, Roux-en-Y gastric bypass, those are associated with severe vitamin D deficiency and shown benefit to improve from vitamin D supplementation. Certain types of medications can interfere with absorption and, or increase absorption. So like Dilantin, taking a look at the medications that your patients are on. But interestingly, in this guideline, they did not say obesity had a recommendation for supplementation with vitamin D. And we also, in the guidelines, there was a lot of controversy regarding how you determine a dark skinned person
mhm.
and the role of vitamin D supplementation in that setting, because we know that darker skinned people tend to have a lower vitamin D level. And so they recommend against checking a 25 hydroxy vitamin D level in this population and against
But I think
empiric
they,
supplementation.
I mean, to be very technical, they suggest, again, because of the low level
True.
evidence, right? I mean,
Yeah.
and people need to
Yeah.
understand these are
Right.
not hard,
Yes.
they're not
Yep.
rules. They
Yeah.
are subtle
because
suggestions.
one of
Yeah.
these things is if you do a test, you want to be able to do something with it, and if what they're finding is that testing people may not improve the outcomes, is that what you're saying? Based on this
That is
evidence.
Based on the,
exactly it. Yes, exactly. And so you're right. They said in adults with dark complexion, we suggest against routine screening for 25 hydroxy vitamin D levels. And that is a very low quality of evidence that they come up with.
yeah. So it's not like people aren't allowed to. It's just like, hey, this is what the evidence shows. We
Yeah.
suggest just not doing it across the board. People
Yeah.
are allowed to, but there's a cost to this. And that's what people don't understand. If everyone just starts checking vitamin D levels, like we're already wasting tons of money in medicine, and then patients want these things checked all the time. For most healthy people, it doesn't matter. Now, I guess I want to say, going back to the obesity thing. So people who have obesity are at high risk of prediabetes and diabetes. So we should be checking them with all the appropriate measures for those things, right? And we're going to get with those measures, basically, complete comprehensive metabolic panels that have glucose and liver stuff, but it also has calcium. One of the true indications for vitamin D screening is like hypocalcemia. So those are things that we'll pick up.
Yep.
And then we're going to find people with prediabetes. And then those people probably should at least be empirically treated. Whether or not they end up having other reasons to check, yeah, we could debate it. It's suggested not to because of the evidence.
How much do they suggest treating, just straight up treating empirically those with prediabetes? Like how many international units?
I mean, so it really, again, they don't exactly make a recommendation.
Okay.
They just give you the recommendation based on what was studied in trials, which is a reference range. So in this, they give a reference range ranging from 842 to 7,543 IUs, which the weighted average is 3,500 IUs daily.
Yeah. And that's just because of all the different trials they did. But so here's something else that I think, people who are upset about, oh my God, they're telling us not to take vitamin D and they're all upset about it. They talk about how this does not, take the place or argue against the daily recommended intake, which is already like 600 to 700 or 800 for most people anyhow. And then,
Absolutely.
a lot of our supplements, a lot of vitamins have like 400 or something in them. And then,
Yeah.
a lot of our fortified food has them. And I will say that when it comes up in question, because, all three of us right now live in northern states and we have a long winter where people aren't getting the sunlight that converts, our skin converts it to vitamin D. I will kind of, based on all the evidence before these guidelines came out, I always told people, yeah, something, you can add in something between like 400 and 2,000. And I feel like it kind of says that for those groups ish, but
it used to be because I
it
used
seems
to
reasonable.
supplement too. I just had mine checked, but it's been summer for a couple months now.
Yeah.
And mine was 44. So I can check it again.
Oh, yeah.
And by the way,
Listen,
pay cash
I
for
have
that.
I have a lot of patients. I'll say to them, listen, you're fine right now, but come that winter, I want you to start on 1,000 units of vitamin D supplementation.
Yeah, that's what
I did think it was interesting in the guidelines. They talk about how the NHANES data from 1999 to 2000, 0.3% of patients were being checked with a vitamin D level, and now it's 18%, right? So when you move over to 2013, 2014, and I'm sure it's even more now.
What's the prevalence of vitamin D, like not just deficiency, not insufficiency, like deficiency? What's the prevalence of that?
Now we don't have those.
We could look that up, but
it's in there.
Because what they're basically saying is that, and this is, I've talked with my buddy. We're going to have him on. He's a nutrition expert, RD, PhD, Kevin Klatt. We've talked about this before because this is why the guidelines are interesting, because before it's like vitamin D, but even, what is it, lower? I see it lower than 12.
Yeah. Mm-hmm.
12 at some point it gets the prevalence or the PTH and the bone loss potential goes really high below like 10 or 12 or something like that.
6% of US adults would be considered vitamin D deficient
if
for that 10 for the 10. And that's like true, like, hey, this is not good, like, osteomalacia type stuff.
Yeah. Okay.
Yeah. Well, my patients always want to know, like, how can I get vitamin D? And I always say, well, it's a little complicated because it's fatty fish, right? So mackerel, sardines, even salmon has it in it. But nowadays you also have fortified foods. You have fortified cereals that have it. So there are natural ways that you can get it as well in your diet. But I think for the most part, the fatty fish is at least in my population, sometimes a little challenging. Maybe by you guys, it's not.
I kind of like Superman. I get my power from the sun. And so I always tell patients, don't tell your dermatologist, but, get a little bit of sunlight. Just don't get burned.
My brother's like one of these keto guys. He doesn't wear sunscreen.
That is not true,
He has not eaten a carb since 94.
I would say that's a controversial topic for sure.
Very good. Okay, so what are some other... So the practical takeaways are people that are at risk maybe get checked or just supplement. I don't know. This is the question. It's like, should we even check them at all?
But the people who are at risk that maybe people out there listening should know and the doctor should know. So let's go over the people who really should be getting checked at risk again.
Yeah. So the people at risk are people that have their terminal ileum affected. So malabsorption, celiac disease, Roux-en-Y bypass, those GI, Crohn's disease, ulcerative colitis. Those are people at real risk for vitamin D deficiency. People that are, as we talked about the pre-diabetes population, people with osteoporosis, right? Hypocalcemia, calcium disorders. The patients that you and I see all day long for sure. I would also say, people as they get older, at increasing age and the fall risk is higher, that for me also is a population I start checking.
They talk about
But again, this
institutionalized
particular
treatment.
guideline is only healthy adults. So
Yeah.
Yeah.
all the recommendations they are making here is really outside of other guidelines. When in 2020 we did the ACE osteoporosis guidelines. Those were for postmenopausal women with osteoporosis. And in those guidelines, we recommended vitamin D supplementation. So about 1,000 to 2,000 units a day for patients with osteoporosis. So again, not what we're talking
Okay,
about here.
here's a good question though, because there are a lot of supplements that are tainted. You hear about these case reports of people getting vitamin D toxicity. They thought they were taking 1,000 international units, and they were taking like 100,000.
Oh my God.
I've seen
Yeah.
case reports like this.
Yeah, that's right.
You have a certain brand, or do you recommend, like, I don't know, you probably don't make any money from these brands, but like, do you have a brand that you're like, hey, I trust this because they're CGMP certified or anything like that? Or
I would say this is a question I get every
Yeah.
day, all day. Yeah. So you want it to be vitamin D3, right?
Yep.
So specifically looking for that. That's my preference. So we know the daily vitamin D supplement is better than the weekly, the high dosing. People love to go on high dosing. It's really not that. I'm recommending the vitamin D3. I happen to like Nature Made because it does have a chewable form that people tend to comply with. But any form of vitamin D3 is really good. That being said, I have patients that do drops, and interestingly, in the guidelines, they do suggest that drops are really fine. But I really do prefer the vitamin D3 daily supplements. And I have a lot of patients who will say, no, you had me on that once a week high dose. My level was very low. And I'll say, you're right. But we did that 3-month course. We normalized you. Now it's really time that we switch over to the over-the-counter.
Yeah, and the interesting thing, the really healthy people are a lot of the people that are kind of the wellness worried well, and they're the ones who this is guidelines. It's like, yeah, you probably don't have to really worry about it, right?
Right.
Yeah. I do want to also just highlight that pregnant population.
Yeah.
They did find in the guidelines that there really is a significant benefit of vitamin D supplementation during pregnancy reduce the risk of preeclampsia, intrauterine mortality, preterm birth. I mean, those are significant findings. I mean, when I was pregnant with my kids, I definitely don't think I realized those implications. And again, they're recommending empiric vitamin D supplementation, and they are not recommending that you check a vitamin D level during pregnancy to assess adequacy. They're just saying start on vitamin D supplements.
I'll bet you took it though.
I would bet you I did take it.
What about the binding proteins and the things that can maybe make it look lower or higher or whatever? Do you know much about that? I mean, I don't know if you guys talk about that.
Yeah, so I mean, there are certain people that have binding protein abnormalities, and there definitely is a paucity of data looking at that to see if we measured this out, maybe we could better determine who would benefit from vitamin D supplements. So, I mean, the analogy has been to thyroid binding, TBG, thyroid binding globulin. Then now we're able to measure it out, and we can determine patients that have genetic issues and maybe they don't actually need to be on thyroid medication. So I do think that's an area that we do need to look at a little bit more, but it would be also specifically looking at assays as well.
Okay. So
and to say also in some places they don't only check a 25 hydroxy vitamin D, they do 25 hydroxy vitamin D2 and D3, and you get kind of this like profile of vitamin D levels. You really just want that 25 hydroxy vitamin D level. I mean, that's what we're doing. I'm sure you've seen this too. I see people that are guided on their vitamin D supplements based on a 125 dihydroxy.
Yeah, thank you for bringing that up.
I was going to bring this up because
explain to people why
we do this all the time. And so the doctors out there listening really need to listen to this, because
don't be checking unless I suppose you're a nephrologist, right?
Well, we do.
You guys
for different reasons, yeah.
Nephrologists check it all the time.
Yeah, so when you take in that vitamin D, you get the sunlight in your skin, you convert over to 25 hydroxy vitamin D, and then later on that gets converted over to 125 dihydroxy vitamin D. That's in the tissues. So that's not what we're looking to measure. We're looking to measure that 25 hydroxy vitamin D. That's the one that we're regulating. So I find that people have this kind of level checked, and people will be like, oh no, I needed to be on it. And I'll say, no, we didn't measure the right variable. We need to remeasure. And they'll say, I just had a test. You need another blood test. This is not giving us what we
significant difference in the half-life of them too.
I mean,
25D is like I always tell patients it's kind of their storage form of vitamin D, even though the 125D does the does the stuff, but it's like several weeks versus like 8 hours, according to what I was able to, like 5 to 8 hours or something like that. So it's
Yeah,
another.
I mean, what I always traditionally told is that the 25 hydroxy level is what like that's the best marker of our vitamin D status. The 125 is like a drop in a bucket. Like
Mhm.
it's very unreliable. Like that assay is a poor assay. It's just not what we want to be using for
Some people
vitamin D.
recommend always getting a PTH with it as well. Is that? I mean, I don't do that, but some people have recommended that in the past.
I think it's important in an osteoporosis
Yeah.
patient to be checking that, or if you have somebody, there's good data actually in celiac disease. If you diagnose secondary hyperparathyroidism and you treat it, you see that resolve. So I think there's subpopulations, but routinely I would recommend measuring that.
Yeah, I mean, I think that gets into other things that end up getting sent to us naturally all the
Yes,
time. I mean,
yes,
we end
fortunately,
up
that's
getting
very
referrals
true.
for hyperparathyroidism
Yeah,
all the time, and it's not always just a
yeah.
parathyroid disease. It's often a secondary thing. And yeah, sometimes they do have low calcium. Sometimes they have a high urine calcium, like somebody I know, and it causes low bone density and, all sorts of other things. And yeah, kidney disease because it doesn't convert that well. And
Right.
so usually that's going to end up coming to us, or at least getting a curbside to us.
Very
Yes.
good.
By the way, that diagnosis of an elevated urine calcium, hypercalciuria, that's one of the best things to find because you can find that the bone density gets significantly better when you treat the
Why
hypercalciuria.
isn't mine
So
getting
you
better
kind of,
then?
It is a little
yours
bit.
I
is.
don't think it is.
Yeah,
God,
Mine. It was the first. I'll send
you're
you.
lucky you had friends
All
that are
right.
yeah,
endocrinologists.
I'm really
Anyways,
excited over that diagnosis. That's a great one to get.
yeah,
I'm
it is.
checking my late night cortisol
Oh
again.
God.
That's why.
All right.
That's why my brother has better abs than I do.
Oh, here we go.
I'm not thinking that you have Cushing's. I think it's a very low
It
probability
is a
just
very
based
low
on
probability. He's
everything
going to
else.
end up getting a false
I'm.
positive and having pituitary surgery and
No,
all this
I'm
stuff.
going to get the full body
Yeah,
MRI.
God darn.
it's not in the cards. I do say I think it's hard to know where to go with these guidelines because now we're pulling away from everything we originally thought was how to treat, right? We're doctors. We like to know this is the right level. Here's where you go with it. You bring them back, you monitor them. And this is saying, unless you're in, the 1 to 18-year-old population, pregnant population, or 75 years of age or older, you really don't need to treat.
Yeah. And a lot of people like that now too, and it's hard for them not to. But I'd still think, going back to what the basic amount that we're supposed to take in, it certainly seems reasonable for people if they have any concern or any chance that anywhere from that daily recommended amount of 600 to 1,000 or even 2,000 a day, like in the winter, still to me seems pretty reasonable. And I'm not so sure these guidelines tell anybody not to do that. They just suggest, based upon the best evidence and low level of evidence, that not to do it across the board, and that's fine. I
You
think.
two sound like a couple of vitamin D shills. No, I don't. I don't really have anything.
But
I think that's
it's
reasonable.
the
I think that's
screening
reasonable.
that costs so much and
Yeah.
is not
Well,
reasonable.
so
Whereas the
that
empiric, and that's why I
that gets
kind of
into
say
the
that.
cost of
Hey,
healthcare. I like
500 to 2,000.
charging. I like charging cash for you make a deal with the labs and you get it for like $10 as opposed to your insurance costing like $200 or $300.
Driving the cost up.
This gets into all the
Oh, no,
healthcare
here we
issues.
go.
Here we're going to get on the soapbox and talk about the cost of healthcare. But
My
seriously,
billers frequently have to deal with the Medicare population if they have a 25 hydroxy vitamin D level not associated with that diagnostic code of vitamin D deficiency or osteoporosis. They're paying out of pocket,
Mhm.
which is like
yeah,
$150 by me.
ridiculous. It should be like
Yeah.
$10.
So
You can contract directly with the labs.
I mean, I think you bring up a very important point, which a lot of this is about cost efficacy, right?
Yeah.
And the cost frequent screening, because we're not really talking about harm.
Right.
The whole guideline, it's not that you're putting people at harm by telling them to do supplements, and it's just that we're not finding the benefit. But they had a very long section on all the confounding factors to these studies, and that it's no longer a possibility to say to patients, okay, we're just not going to give you vitamin D, and we're going to give this other population vitamin D, and we're going to follow you for 3 years because the risk of that is potentially high, and so we just can't do the studies.
Yeah. All right. Well,
Yeah.
any other practical takes? I think it's good. I think for anybody that's obsessed with vitamin D or somebody that's obsessed with vitamin D, send them this. We'll put the new guidelines in in our little show notes or whatever, so you can click on it.
And where to follow you for social media? You've been throwing in some social media efforts here and there once in a while, right?
Yeah. So Dr. Pess, Dr. Pess on X. And I always love to retweet, so feel free to tag me. But this is a super hot topic, and my takeaway is I can counsel a lot of patients that maybe they don't need to be followed so frequently for their vitamin D level, and maybe they don't have to worry as much, but we are going to empirically start based on the Institute of Medicine guidelines.
Very cool.
Thank
you so
you.
much. Here's our
Thank you so much for having me. Enjoy the rest of the summer.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.